Can a person with type 1 diabetes fast? Yes. Can any person with diabetes fast? Yes. Are all people with diabetes or illness and they should not fast? No. So we need to select carefully.
Evenings Med Pod with Dr. Hanan.
Hello, everyone, and welcome to this special episode. This special episode is brought to you by Ithnain. Ithnain is your medical plan backbone, where we're extending your care beyond the clinic. This educational series is directed to healthcare providers who are interested in diabetes care. I'm your host, Hanan Taib. I'm a family physician and consultant of diabetes in Riyadh, the capital of Saudi Arabia. And joining with me today I'm so privileged to have Dr. Mohammed Hassanein. Dr. Mohammed Hassanein is a prof of medicine and endocrinology consultant in Dubai Hospital. He's the chair of DAR International Alliance, where he and his team set a great guidance to all of the diabetologists and healthcare providers among the world in dealing with diabetes during Ramadan. He has been recently awarded with the award of health award in health innovation from Hamdan bin Rashid Al Maktoum Foundation for his innovation in diabetes and Ramadan risk calculator. Welcome, Dr. Hassanein.
Assalamu alaikum. Welcome.
And as we all know, Ramadan is a very special and spiritual time to all Muslims among the world. So would you start telling us, Prof, what is it exactly DAR International Alliance? How did you start, and how did you and your team come up with such great alliance?
Well, 2005, I was invited among other group to join together and write the first consensus on diabetes and management during Ramadan, along with the AGA. It included actually from Riyadh, the eminent Dr. Khalid Rubayyan as well. And after launching these guidelines, it became clear to me that across the globe, there is so many people who are not really sure what to do during the month of Ramadan. Whether where I was working in UK and Europe, or whether indeed even in Muslim countries such as Saudi Arabia and Egypt and elsewhere. So we started to do more awareness and more studies and more research. And I realized that we actually need an umbrella for this, rather than just a group of friends. So by 2013, we set the Diabetes and Ramadan International Alliance among a group of colleagues in collaboration with a couple of organizations, all volunteers, the Diabetes Education Study Group of ESD, some of the members of the IDF, Africa and MENA region. And then gradually DAR became a well-known category by the effect of all the volunteers, and we produced two more new guidelines along with the IDF, as well as a numerous amount of research. As I repeatedly mentioned, it's all volunteers. So no office, no secretaries, none of this sort of organizations that many people do have. But as you rightly said, Ramadan is very important to all of us, and we're all very passionate about it. So we set it to understand more, to try to find out how can we make Ramadan safer and raise awareness about the new information. So yeah, I'm delighted we are where we are.
Well, that's a great story, because it's really challenging. I could imagine how it's challenging and how much effort you are doing to put all of this together. So you've mentioned there are recent updates, and I think I came across a recent publication by yourself in 2024 trying to trying to summarize the characteristics of patients who are fasting Ramadan of type 2 diabetes. Would you talk about that more?
Yes, we as DAR, we set up a large study among the volunteers from as west as Morocco to as east as Indonesia. Indonesia actually is where I'm going in 2 days to be with them and present on some of the awareness ideas. So the data we collected was from about 250 investigators. It included 12,500 persons with type 2 diabetes. from Maghreb countries, from Middle East countries, from Gulf countries, from Indian subcontinent, and from Southeast Asia. So these are the five main geographical regions. We looked into the characteristics of people. Who are they? I mean, because this is classic people with type 2 diabetes, kind of average age in their 50s, nearly split between men and women. What's their baseline characteristics? What type of therapy? I mean, 40% of them are on insulin. And when you look into fasting, we realize that 85% have decided to fast. Of those who, so 15% did not fast, obviously with huge variation. Countries such as Saudi Arabia and Bangladesh, the vast majority are fasting. Other countries have much lower rates. And by the way, this does not mean at all that they are any less religious. It just means that the interpretations of the clinicians, along with the community there, for example, if a person is on insulin, then they consider that person high risk automatically, don't fast, period. So, but obviously it varies. So what we noticed from the data from the survey is, as I mentioned, 85% fasted. Out of those who fasted, 11.7% had to break their fast because of problems. 15% had hypoglycemia. And in those who had hypoglycemia, nearly 11% required to go to the emergency department or get admitted to hospital. Now, Ramadan is not just about hypoglycemia. We overindulge in Ramadan. The month of fasting becomes a month of feasting. And interestingly, rate of high blood glucose levels were 16%. And again, 11% of them required to go to hospital because of the high blood glucose levels. So, in summary, the vast majority are able to fast. 60% of those who fast the whole month. But nevertheless, there are many who are, or a sizable minority who have problems, who decide not to fast, or who fast and develop problems. And hence, our role as clinician is to pick that bad apple from a basket and either advise them not to fast or work with them to make the fasting a lot safer.
As you correctly mentioned, that there is a huge gap in a lot of countries among the world between the knowledge of the physicians and how to deal with Ramadan and how to deal with such medications, and is exactly right. Like, we are not everywhere aware of that. So thank you for pointing that out. So you've mentioned it's not only about hypoglycemia, but there is also elements of hyperglycemia. So you are pointing to a lot of challenges that the patients might face during Ramadan. Can you tell us what are the main challenges that those individuals might face?
The classic challenges are mainly four: hypoglycemia, hyperglycemia, dehydration, and in a small minority, ketoacidosis.
Mhm.
The question is, who would get this? So not everybody is the same. It might be the same pathology, but in different social circumstances. Let's say that your brother works as a field engineer in a construction site, exposed to the heat and up and down, and not sorry, brother, let's say two patients, two twins. One works in an air-conditioned office, and another is in this physical demanding job and heat exposure. Now, it's completely different exposure. I just came across a recent study published in Pakistan, in Peshawar, from a tertiary hospital. What I noticed that the majority of the population of the study were people with manual work.
Mhm.
And interesting, of those who were considered to be high risk, 43% of them opted not to fast,
Mhm.
which is much higher than what you expect in Peshawar in Pakistan. Why? Because they know they are high risk and they know that their job is physical. So they would be losing their income and realize that, yes, I cannot cope with this. So, and actually, if you were to read that interesting study, which I just came across about a couple of weeks ago. In the high risk group, those who did not fast, 8% of them had hypos. But in those who fasted, 56% had hypos. So you can see the huge difference, and you can see that the classification of high was accurate.
Mm-hmm.
And our job as clinicians is to be honest with our patients and to, in a nice, friendly way, explain all the issues. Nobody is more merciful, more rahim on human beings more than Allah subhanahu wa ta'ala. Allah subhanahu wa ta'ala said in Quran, Man kana maridan aw ala safar. Allah subhanahu wa ta'ala in another ayah in the same surah said, وَعَلَى الَّذِينَ يُطِيقُونَهُ فِدْيَةٌ طَعَامُ الْمِسْكِينِ. And in the same ayah, in the same surah, sorry, Allah subhanahu wa ta'ala said, يُرِيدُ اللَّهُ بِكُمُ الْيُسْرِ وَلَا يُرِيدُ بِكُمُ الْعُسْرِ. This in Arabic is a term of strong demand, do not do that. So Allah subhanahu wa ta'ala, لا يريد بكم العسر. So unfortunately, some patients, and I today had one of these patients saying to me, I thought that when I push myself harder and harder, that I will get more thawab.
Yeah.
And I said to him, no, Allah subhanahu wa ta'ala gave you a license. And if you to harm your body is amana, your body is something sacred. And if you to harm your body, Allah subhanahu wa ta'ala says, وَلَا تَلْقُوا أَنفُسَكُمْ إِلَى التَّهْلُكَةِ. Do not throw yourself into jeopardy. So all of the Quran and the Sunnah are advising us to look after that body, to protect the body, and to use the license. I find it very interesting. It's all about our passion for fasting, and perhaps have a misunderstanding of the demand from us. So when we travel, we pray Dhuhr and Asr 2 rak'ah, not 4, and we merge Dhuhr and Asr. And people are very happy to do this. But when it comes to not fasting, they are extremely reluctant. So I know it's a pleasure, but I also think that our role is to highlight to people, protect your health, protect your body. This is an important message from Allah that requested from us. So if I'm at high risk and I came across patient says, what will happen to me? I die? I die as a martyr fasting Ramadan. And what the ulama says, no. If the expert doctor said to you, do not fast, it's harmful for you, and you end up with trouble, you are not gaining thawab. It could even be the opposite.
Definitely.
So I think, unfortunately, many people are not getting that message, and they are keen on pushing themselves harder and harder and harder towards the risk of harming their body. And it's only a risk. And we need to understand it's a risk. It's not guaranteed, which is, I'm sorry, I'm dwelling a bit of it on this point, but it's a really crucial point. It's exactly as if the risk of smoking and health issues. Does every smoker get a heart condition or cancer? Of course not. Many people carry on smoking for 40, 50 years and never get anything. But did that ever stop us from writing on the cigarettes packets,
No.
smoking kills, smoking causes cancer, smoking causes heart disease and whatever? No. So it's important that we understand we are talking about a risk. When a person jump from the balcony of the first floor, are they all going to die? No, but it's hazardous. So we say to people, don't do that. So it's important because many people said, well, you know what? You said I was high risk and I did it and I had no problems. Well, this is a gamble and we do not need to gamble. Having said that, again, what I'm saying, 85% fasted. Out of them, 2/3 fasted the whole month with no problems. So for type 2 diabetes, the majority are able to fast. But for some because of maybe health issues, type of treatment, maybe social circumstances, or work circumstances, they can use their exemption.
Well, I'm so glad that you pointed that out and you emphasize it, because it's a really important message, even to us as healthcare providers, that we need to put those patients kind of in consensus with their healthcare risk. It is a risk when you push yourself to fast when you are not ready to do that. So going back, doctor, to the word risk, like you are pointing out to a way of for us as a physician to understand how do we classify those patients. Is there any tool that can help us?
Very much so, yes. There is, put it this way, with many aspects in health, in diabetes, for example, we have guidelines and we don't argue about it too much. The margin of argument would be what is a good glycemic control target, less than 7 or less than 6.5. So it's a narrow margin. What's a good blood pressure? What's a good LDL? Correct?
Definitely.
But when it comes to the decision of fasting, if you sit and throw in a case scenario, you will find easily three different opinions: high risk, moderate risk, or low risk for the same case among doctors from the same city or even the same center. And that is confusing for the patient and
Yes.
makes them don't trust the message they get. So we developed the risk calculator, which we won the innovation award for from Sheikh Hamdan Awards. The group of us who wrote the last guidelines, we looked into the previous tables that quantified for risks. Now, the tables were a bit rigid. For example, you would say type 1 diabetes, very high or minimum of high. But what if this person with type 1 diabetes is doing a hard physical job? Or what if this person, for example, have a CGM and an insulin pump and they are very well controlled? Are they at the same level? Take someone that you would say to yourself, oh, that's average, that's okay. I'm a patient maybe with unsulfonylureas, multiple oral therapy, and maybe basal insulin. So many people would say that's okay, not too harsh, but add to it a kidney problem or a cardiac problem or a physical job, or unable to poor and not able to do SMBG. So it throws away or throws completely the situation of the person from one level of risk to another level of risk. So we developed the risk calculator. I'm delighted that in the DAR Academy, if maybe you can see the picture, don't know, yes, here you can possibly see it a bit
Yes.
better.
Yes, it's
If
a
you
great.
can see it here on the bottom of the screen. So this is the DAR Academy app. And on the bottom of the screen, there is the risk calculator. Once you press the risk calculator, you will go through 14 different elements: the type of diabetes, the duration of diabetes, the frequency and the recognition of hypos. So just imagine you if kids in school are being driven to school by a driver who is fasting and does not feel the symptoms of hypos, not only he can harm himself, but he can harm lots of people.
Yes.
So the recognition of hypos, the severity of hypos, the frequency of hypos, the type of therapy. Am I on intensive insulin or am I on a GLP-1 and metformin? Two drugs that cause very little hypos. What is my current level of glycemic control? I told you 16% reported significant hyperglycemia, and out of them, 11% required to go to the emergency department or be admitted to hospital. Do I have cardiac problem and what level? Renal problem and what level? What is my cognition? What's my age? What's my level of frailty? Maybe I'm young, but I'm frail because of my health. Am I able to monitor or not? Have I had a recent episode of ketoacidosis or hyperosmolar state or not? My own previous experience. So maybe you would say I'm high risk, but I sailed through Ramadan with no problems. or the opposite. Obviously, let alone the issue of pregnancy and breastfeeding, where here the level of the risk goes beyond the person to another person that is unable to say anything. So I say to the ladies who are pregnant and they want to fast, I say, you want to fast, but is your baby able to fast? Do we know that it's safe for that baby? And if we don't, then why take the risk? Pregnancy is a temporary issue. So if I have diabetes and I'm pregnant, then next year I will have diabetes, but I'm not pregnant. So if I'm so keen on fasting, I can compensate for these days. And we should not, because of convenience, of course, it's more convenient to fast when everybody is fasting, rather than the lady would fast to compensate for these days on her own. But convenience should not be a good reason to put the baby, the fetus, into jeopardy, let alone the mother herself.
Definitely, definitely. And we face those patients, and really it takes a long time to take that discussion along with them. And as you said, 85% of our patients, or probably more, will insist in fasting no matter what we try to explain to them. But of course, we have to do our job in that perspective. Let me ask you.
Yeah, just on this point, Dr. Hanan, this is crucial because me as a clinician, going home and sleeping calmly in my bed, I need to feel that I've done my duty
Definitely.
and not gone with the flow. Going with the flow, and the patient says, "No, doctor, I will fast." Okay, fast, and let me do advise you on one, two, three. I need to explain to my patient clearly. I need to explain the message clearly, and then it's up to them to take the decision. But me, in front of Allah subhanahu wa ta'ala, I want to say, I have done my best duty to explain the level of no risk or low risk or high risk. We very rarely come across someone who want an excuse not to fast. And I simply say to them, looking into your profile, I have no reason not to advise you not to fast. But then it's your call whether you want to fast or not. Don't ask me for a stamp to
Yeah.
make your decision. Sorry, I interrupted you.
No, definitely. This is a really important message that I need every one of us try to think about it, because it's not easy really sometimes to do all of this in the diabetes consultation, a really short time, but really important messages that we have to deliver. So I just wanted to ask you, doctor, as we all know, type 2 diabetes specifically is a progressive disease. So most of our patients is on one or more than one option of therapy, especially those on multiple doses of insulin per day. In very concise way, as much as you can, how would we think about managing the medications? How would we advise them? Because there's a lot of questions. When do I take my medications? How do I taper down the doses? How do I prevent myself from having the complications with those medications? Any advices?
Sure. There's lots of medication which I call Ramadan friendly. Let's say they would have a green color. DP4 inhibitors, metformin, GLP-1s. None of them have high risk of hypos. They are rare to cause hypos. And consequently, there is no need to reduce the dose. So if it's a drug that has been taken once daily, take it at iftar. If it's taken twice daily, then take it at iftar and suhoor. If the person takes it 3 times a day, then you can either decide on dropping one of the doses or merging two at the big meal time, such as metformin, for example. Now, there are other drugs that are in the slight orange, like SGL2 inhibitors and sulfonylurea. SGL2 inhibitors, because of the fact that they induce thirst and polyuria, no need to reduce the dose. They have been shown to have no issues with ketosis, with dehydration, or with impaired renal function. It's just an extra sense of thirst for some. And hence the advice here is take it at the meal time, iftar time, and don't reduce the dose, but drink plenty of fluids during eating hours and drinking hours, and avoid excessive diuresis by excessive caffeine and excessive salty food. Then the other orange level is the sulfonylurea. Older generations of sulfonylurea would cause more hypos, such as glibenclamide. The more modern ones are much lower rates of hypoglycemia, but we know that sulfonylurea can cause hypoglycemia. If it's once daily, I would take it at iftar time. If it's twice daily, iftar and suhoor. Should I reduce the dose? And the answer is yes, if I'm average control. So we did one study where people were HbA1c was around 8, and the physicians did not reduce the dose because it was not tight and there was no problems. The rates of hypoglycemia were pretty low. But if the person is well controlled, or if the person's job is hard physical work, or if the person's lifestyle is of those who keep snacking all the time. So they have breakfast and then they have a bit later a cup of tea with a biscuit or a cake and then an apple here and a sandwich there. Those people, when they are fasting, they definitely need to reduce the sulfonylurea dose by 50% because they are missing the constant calorie intake that they do. So express your own skill and decide on whether you would reduce the dose of sulfonylurea or not based on the HbA1c level of the individual, the physical activity nature of the job of the individual, and the frequency of eating and snacking during normal days for the individual. Okay, then we're left with insulin. More or less the same principle. If the person is poorly controlled, no need to reduce the dose. If the person is well controlled or averagely controlled, then the basal insulin or the mixed insulin dose that they take in the morning should be reduced by 25 to 35%. Bolus insulin matches the food intake. So I'm having a big iftar, I need a big bolus. For suhoor, the person is going to be fasting afterwards. So give him the dose, but give him a smaller dose for suhoor. But the most important part in all of this is to provide your patient with a simple algorithm. Algorithm is sort of modified for Ramadan. And what we say, aim for 90 to 126 milligrams at iftar time, at end of iftar time, kind of like the fasting time. And above this, increase the dose. Below this, reduce the dose. How much you reduce or increase depends on how far you are. In those who are in very high doses, we say 10 to 20% of the dose. In those who are on small doses, we say 2 to 4 units, up or down.
Definitely. So, is that the same advices that we are giving to our patients with type 1 diabetes?
Well, type 1 diabetes automatically comes at a higher risk because they are absolutely dependent on insulin. They would normally get 1 or 2 hypos a week. So level of risk is there. Once you address the risk and you advise them, then if they are on basal bolus, it's the same principles. Give the basal insulin at iftar, reduce the dose by 25 to 35%. The boluses would match the carb intake, but the bolus at suhoor need to be reduced.
Is the integration of the new technology in treating type 1 diabetes, such insulin pump and the CGM devices and others, does that change our thinking when we advise them, especially those with insulin pump?
Of course, let me explain that we have 2 issues here. One is the monitoring, and the other one is the delivery of insulin. So the monitoring is beautiful because if I have on my phone the app that shows my blood sugar levels all the time, then in theory, unless I'm asleep and the alarm is switched off or doesn't have an alarm, then I can never have a hypo because I simply can check every hour as you check your phone or WhatsApp or Instagram or whatever. You can have a quick look, and if it remains in good normal range, you're safe. If you start seeing I'm going low or heading towards low, then do something and stop it. And the simplest thing to do is stop the fast. Okay, so this is the beauty of the technology. One issue with the CGMs and low If the person is completely asymptomatic and they have good hypo awareness, then they need to double check because sometimes the sensors are not as sensitive in the hypo range.
Mhm.
And the decision of breaking the fast is an important decision. The decision of should I fast, should I drive my car now or not is an important decision because there is a big difference between 100 and 70.
Of course.
So in one, you'd say good control. In other one, you might say, no, I wouldn't trust my reflexes. So the monitoring is fantastic. It gives lots of information, but we need to understand the weakness of the monitoring with regards to the asymptomatic hypos. If they're symptomatic, trust your symptoms.
Yes.
Even if the figure says normal, you feel hypo, it's hypo, full stop.
Mhm.
Then come the advantage of the delivery. The injection, you can once you're given the injection, you have no way of adjusting the injection. But with a pump, you can slow down the rate, you can stop the delivery because it's producing the insulin minute by minute. So you have a way, and we see the technology of pumps, specifically the closed loop pumps, where the pump is linked to the CGM, they talk to each other, and the delivery of insulin is dependent on this. It's like kind of like an artificial pancreas. And in these people, we see fantastic low rates of hypos. What sometimes is not so fantastic is the delay between the surge of the sugary stuff and the high carb stuff and the pump realizing that I'm high to correct. So with a bit of input from the clever doctor and the clever patient or person with diabetes, they can overcome the hyperglycemia. But certainly technology can help many people on insulin therapy, whether they're type 1 or type 2.
Yes, I think we are so privileged to have this technology, which makes things easier than it used to do before. Dr. Hassanein, I want to ask you the last question of the day. What are the main, or what are the, we usually hear lots of myths around Ramadan, lots of misconceptions or wrong beliefs from the patients. I would just give an example in here. Some patients, they avoid taking the correction doses of insulin during the fasting because they believe it's going to break their fast. Can you tell us more?
Indeed, there's lots of myths in Ramadan. Some of the myths we already discussed. Can a person with type 1 diabetes fast? Yes. Can any person with diabetes fast? Yes. Are all people with diabetes or illness and they should not fast? No. So we need to select carefully. That's one of the myths. The myth with, for example, doing the SMBG in some communities and some, obviously, we work in the Gulf and we have people from lots of backgrounds. In some countries, they believe that the blood breaks the fast, which is obviously a myth as well. Insulin, some people believe that insulin break the fast, and it's not. I'm not a strong advocate for correction doses when a person is fasting, because I believe that more important than the correction dose is understanding why it happened. And in many cases, we see people with type 1 hooked on the correction dose without thinking why. And if they focus more on the why, having a high glucose level on one day is not such a big deal. If they understand why it was high, they will prevent it in so many other days. But if they just get hooked on it's high, let me take 2 units, 4 units, 6 units, and without thinking why did it get high, they frequently never get better. So yes, the injection doesn't break the fast, but I'm not a strong advocate for correction doses, especially for someone who's fasting. Therapy such as SGL2 and sulfonylureas are dangerous. Myth. No. No problems with regards to either of them. Slight reduction in the dose for sulfonylurea if a person is well controlled. And for SGL2, no need for dose reduction. Just make sure that your patient would have plenty of fluids. I don't know more about other things. Yeah, I'm not sure. Some people are not keen on suhoor.
Hmm.
And sunnah is to have late suhoor. So many people, especially those who are going to work, they say, "Oh, I'm not too hungry. I will eat something at at midnight or 1 a.m. and I would rather enjoy the sleep." Now, if I'm a diabetic person, especially on insulin or sulfonylurea, then I'll be increasing my fasting hours by doing so. A late suhoor that includes plenty of protein and fiber. One of the myths is thinking that have sugary stuff to compensate for the sugar.
Yeah,
That's obviously the opposite that you want. You
definitely.
want protein and fiber, and protein usually has a bit of fat in it, and both last longer in the system without
Yeah.
increasing the blood sugar levels significantly.
I might add one of the things that always my patients ask about the best timing of exercise. They say that we
Yeah.
should exercise before the fasting, the breaking of our fasts. So is that wrong? Is that right?
I tell you what, I come from Alexandria in Egypt. We have a huge sporting club with a huge walking and jogging track. That jogging track in Ramadan, you cannot jog, you can maximum walk because it's packed with people who are
Wow.
doing exercise.
Mhm.
But if I'm a person with diabetes, the highest risk of hypoglycemia is between Asr and Maghrib. So this is the worst time for me to exercise if I have diabetes. That's I can always exercise in the evening after Taraweeh or in the evening. That doesn't mean that Ramadan is a month to sleep. Light to moderate exercise is no problem, but intense exercise is better to be done when I'm able to eat and drink.
I couldn't agree more. So, Dr. Hassan, it was a wonderful discussion, and I personally want to go on with such expert like you and learn from your wisdom. But because for the time restriction and definitely for your sake, how would you like us to end this discussion? Any final thoughts, any final messages that you want to deliver?
Be safe. Ar-Rahman Ar-Rahim says, يريد الله بكم اليسر ولا يريد بكم العسر. Be safe.
Thank you so much. It's a real pleasure to see you, and I hope next time to see you physically, not through the screen. Thank you
Inshallah.
so much, and have a wonderful day.
Thank you.